Wonderful. Well, those of you who know me know that since I started at the Institute, one of my biggest focuses has been on the behavioral health crisis continuum, and it's really a joy to be here with the three of you today. Partially because what's come up on every panel and every discussion so far this morning has been how distinct and siloed our programs are. We often say, we have 58 different behavioral health programs around 58 different counties. And I think what's so uniquely challenging about crisis care is it's not just behavioral health. And it's great to be here with behavioral health, of course, but also our law enforcement and fire and EMS partners to talk about how we can all build a system that works towards a compassionate crisis care system. And excited to dive into what's working today, where we are, but also what the future is, especially as the landscape is changing. So I'm going to start right there, kind of setting a baseline, which from each of your vantage points, and if you could briefly introduce yourself and your role in the system when you answer. How would you describe California's behavioral health crisis system, where it's at? Where are we meaningfully better than 5 years ago, and where are the gaps?
Good afternoon. I'm Kelli Weaver. I'm the Deputy Director with Sacramento County Behavioral Health Services. And I've been in this work for a little over 3 decades. And I have a huge passion for crisis services, back pretty much all of my direct care services within crisis care. And I'm really pleased with the progress that we've made over the last 5-10 years in building out our crisis continuum. I can't state more diligently in having a robust continuum. We've had inpatient care for decades. That is a highest level of care when there are so many other levels of care that we really need to support. So recognizing that 911 has been a familiar resource for our community. It's the place we teach our kids where to call for help. That in the space in the last 5 years is really looking at an alternative option for our community members. Recognizing, introducing 988, but then we need more than just a call center. We need somebody other than law enforcement to be able to go out on those calls. Recognizing the important roles that we all play, that our law enforcement partners, what they bring around public safety, what our clinicians and our persons with lived experience, our peer specialists bring to helping people in crisis are so critical. So how do we bring all of that together? And I just want to be able to say Sacramento County has really invested in this work. We started our co-response teams back in 2015. We started with 2 teams. We grew to 11 teams. In this last 3 or 4 years, we implemented a non-law enforcement response as it was about a year before 988 launched, and we partnered with our local region 988 provider to work together in developing processes, bringing our law enforcement partners and our EMS partners together to look at how our systems can work together. We've come together on numerous occasions to look at various scenarios, to look how we collectively define what a behavioral health call is. Recognize there's so much complexity. If this was easy, we would have fixed it years ago. And so that's really key. In addition to a call center and having behavioral health response, for folks that might need more than, or you can't resolve it in the scene, having a place for them to go. And so when we launched our community response team, we expanded our mental health urgent care clinic so that we had 24/7 response. It's really important that our community has access when they're in crisis. They have a place to go, for our partners to have a place to bring folks that are in distress. Maybe they don't need a 5150. 5150s, we talk a lot about that there's gaps, that folks aren't always gonna be eligible for that level of intervention. So then what? And that's really where our urgent care center really holds a place in our community. And so pause there and pass it over to my partners.
Thank you. Good afternoon, everybody. My name is Todd Henry. I'm currently the chief of the Davis Police Department. I've been there about 3 years. Prior to that, I was with the Sacramento County Sheriff's Department for 25 years. So if you do the math, it's a long time. So I've had the opportunity to kind of work in 2 different systems of co-responder, one in Sacramento County, and I was lucky enough in 2015 to actually be part of that expansion of the pilot and really get involved in it, including actually sitting with the panel as they interviewed clinicians for these positions, which I found to be extremely insightful. So I've had this opportunity to kind of see 2 counties who are approaching it kind of in different ways, but with similar overlap. I think the interesting dynamic too, as we talk about, hey, how are we, and are we getting better than we were 5 years ago, 10 years ago? I 100% believe we absolutely are. There's been shifts. It's hard when they're incremental changes to see that change. But when we do look at how services is provided now and just the collaboration, it is a lot better. And what was interesting for me is actually we had the opportunity to kind of pre-meet to talk about this event and kind of our processes and our programs to see how they overlap. And I think universally, we are getting to this space of really kind of defining it as a 3-prong approach, right? It's a place to call, it's somebody to respond, the right somebody to respond, and then a place to go. And I think all counties are, struggling in probably different areas of those 3 prongs, but we are absolutely improving this process on a regular basis. And I think when we look forward in 10 years, we're only going to build on this. And, these are hard programs to implement for a lot of different reasons. And they're complex. Theoretically, they seem very easy. We're just going to do this and it should work. The problem is operationally and practically, how do we actually get it to work? And that's where all these, I think, sometimes hurdles can present themselves. But what I've found with every complex problem that anybody tries to solve, when you bring everybody together, when we're all on the same page, we have some amazing, brilliant people in this space across multiple disciplines. And we really are getting to that space where we're starting to harness that brain power, and that's what I call it. Because we have to see these problems from different perspectives, different angles, and we all bring something to the table to be able to solve it. And so I think, are we going to see improvements? Is it going to get better? Absolutely. And it's going to get better through collaboration. And I think that needs to be the emphasis of anything we do, because the systems may change, the processes may change, but if we're solid in that space, I think we're going to see true success.
Thank you, Chief. Thank you. It's a pleasure to be here. And is it going to change? Of course it's going to change. I've been in EMS now for 40 years. I started out as a paramedic many years ago in Oakland. It's an inner city, and it has a lot of challenges, especially with mental health. And then I moved on into San Ramon. You may not know where it is, San Ramon Valley Fire Protection District. It's somewhere in the East Bay in the northern part of California. I agree with the panel. I think that there are significant changes that we've experienced. I've experienced significant changes throughout my career. The EMS state in California 40 years ago were majority EMT transports to a hospital. They transitioned into the paramedic. There was a very dramatic change in the way we do business and very effective. And then we would respond to, and it was stagnant at the beginning, we would respond to what our crews referred to as 5150s without even really knowing where that number came from or what it represented. But it did represent a desire on the part of the state, as a result of the work and the efforts on the part of all the people that are involved in mental health, to make something change for the people that needed it. And that was the best that we had at the time. If you looked at our fire engines 40 years ago, it's pretty much similar compared to what they look like now to the mental health 40 years ago to the way it is today. So that's where we started at San Ramon. Our number one priority is the community, is to respond to patients in dire need. Many of the times they're in a horrible state. Family members on scene are in a horrible state. They themselves are going through a post-traumatic stress. But dealing specifically with mental health calls, something that We had very little training in our paramedic classes or the paramedic school because there's so much information that we have to absorb in a 6-month period of time that just seemed like one of the back burner topics with government agencies and all the other stuff that kids that are going through school don't want to know about. When I experienced the calls in the field, one of the things that was very clear to me was that it seemed to me that they decided that everybody goes to the same place and everybody gets treated the same way. Now, if we were to do that with our patients on the medical side of it, all of our trauma, all of our cardiac, all of our stroke patients would go to the same facility, and that just doesn't work. You need to specialize each of these individual calls so that they're getting the best level of service with the technology that we have available to us, and that's going to have a significant impact on how we deal with these calls moving into the future. So what San Ramon did to address the problem that we saw in the field, our boots on the ground, our men and women dealing with the patients who were being 5150'd, would come back to the EMS division and say, something's wrong. They would transport a 6-year-old on a 5150 hold to the county hospital, and in the county hospital they were overworked, they were understaffed, many patients wandering around in the hallway, a lot of adult patients, and it was very scary for these kids. So we approached our chief and said, we need to do something about this, and he, being a very progressive chief, sat down with labor. I was a union president at the time, and the two of us came up with a plan. And the plan was, well, let's look at the call from the very start. Now, at the same time, 988 was being implemented. And we were looking at it from the perspective of, what would you rather have respond to? No offense, Todd. Who would you rather respond to your house when you're experiencing a mental health crisis? A big, bulky dude with a gun on his side and a vest and a camera, or a cuddly, fat firefighter with a smile on his face and he just wants to help you out?
You said it, I didn't.
Now, we realized that was important for us, and the police department we work with in San Ramon agreed. One of the things that our firefighters recognized on scene was everybody was in disarray. Our police officers were scratching their head. We have to 5150, that's the code. The medics were scratching their head. Why are we transporting this kid? Why are we transporting this elderly patient with need for medication or Alzheimer's patient to the same facility? It doesn't work that way. So we came up with a new system. And our system requires that our dispatchers are also trained up in mental health. They're trained to receive calls and either to transfer those calls to 988. It's a direct transfer. And 988 takes the ball on 8% of our calls, and they process them over there. The rest of the calls, if they're non-threatening to the fire crews, if they're non-threatening to people in the house, if somebody's life is in danger, those calls that are threatening will go to the police department. All of the other calls will go to the firefighters first. We have PD respond with us just in case it turns into an incident that we can't control. And they stay at bay. They're in staging. So our crews go in, and then we start working the process from the kindler, gentler, because we now have the ability and the authority to do it, whereas the police department, God bless them, they couldn't do that. They were given the direction that if somebody's a threat to themselves or others, you have to 5150 them. They couldn't do anything else other than that. The liability was there. So we realized now we have some tools at our disposal. And by the way, it didn't cost that much for us to do this. All it did was take in a couple of ambulances and moving them around and then redirecting our crew members. So we're saving a tremendous amount of money for the county, a tremendous amount of money for the city of San Ramon, for the police department because they have more boots on the ground rather than staying at these houses for an hour and a half to process the call, and the patients themselves. Now, the best way I could describe this without going on too long, because I could talk about this forever, the best way is when we were implementing the program, we had our members and our citizens show up to our board meetings because we wanted full buy-in. We wanted to introduce it to our community, and we wanted to get their input. And time again, a community member would come up to me and thank me in tears sometimes and say how they had a mental health crisis, and the big burly police officers came. They 5150'd. It seemed like they were being arrested. They were going to the hospital against their will. And when we were implementing this program and introducing it to the community, their response was, oh my God, there's so many times where I would have called 911 for a mental health crisis, but I didn't, because I didn't want that experience. And now I feel that I can. So for me, we could look at stats and we could look at the numbers and how much more it's improved. If we improve one life, it's worth it, right? One life, and we've improved our system and the way we do business. With technology, we're now looking at telehealth for our crews so that we can possibly do the same thing with medicals, and utilizing telehealth with my research, I've discovered there's some counties that are using telehealth for mental health also. So the future, as the chief mentioned, looks bright ahead. And the last thing I'm going to say, because I think there's one more thing that's important for me to say, the chief and I, when we worked together, we didn't accept no for an answer. We decided that this is what we're going to do as long as we're right. One of the things we kept checking ourselves. I don't know if that's right, Mike. But as long as we were right, as long as we knew that what we were going to do was a better system, a better way of doing it, we ignored all the naysayers, because there's a lot. We ignored all the people that were going to create obstacles for us. Oh, you can't do it. The county needs approval. The state needs approval. This is alternative destination. It's a big nightmare. No, we decided this is what's right for the patients, what's right for the community. So we went full ahead. And looking at the challenges before us, moving forward with all the cuts, the government cuts that are coming, if they come, hopefully they don't. But with that, there is a way to do it better, and there is a way to do it better with what you have. And that's what I've noticed from the time I started 40 years ago. So that's where we are.
Really, yeah. I think the shift to just the mechanics and order of operations really highlights kind of the need for the operational practicality and the need for collaboration and how that can impact the whole system and get everyone working together. And I love that example of how 988 offered kind of an opportunity to re-examine how things were working, because it is a big opportunity. It's a big challenge. It's a huge disruption to the way we've been doing crisis intervention for the last, 50 years. But it's also a big opportunity to rethink the way we've been doing it. And what I love, we did have a pre-meet to talk about this, and what I loved about the conversation was hearing how in each of your distinct roles across 3 different jurisdictions, you're thinking about the integration of 988 and getting us closer to that full vision of having people diverted away from 911 first and foremost, and then thinking about getting the right people to the right place. And so I'm curious, on a practical level, how is the integration of 988, 911 crisis response going in your respective jurisdictions, from the call routing to the dispatch and the coordination, and what's going well, what's breaking down, so we can try and course correct? Sure.
I would just like to just acknowledge, I know one of our 988 partner is in the room, and want to thank them for lifting this up in partnership. And I think there is a lot of really positive things to say about the introduction of 988 and the intersection around how we integrate our system partners. I think this is a work in progress. I think the meetings that we've had with our partners, learning each other's processes and systems, recognizing there's this was an eye-opener for me, learning that there's 911 dispatch, then there's a comm center, and then there's patrol. So for our law enforcement partners to understand that there's phases of calls. And so if 911 dispatch as their protocol includes warm handoff to 988, if that's not the same protocol for the comm center or for patrol, then there can inadvertently be gaps in the process. And so you may get warm handoff here and a referral here. And if somebody doesn't follow up on that referral, then it feels like the ball got dropped. So those are learning opportunities for all of us, but it requires us at the table having the conversations, walking through the steps, and trying to avoid disasters, right? We are all on a common ground. We want to serve our community. We want to serve them well. We want to make sure folks that are in need are getting the help that they need from the right folks that need to show up to help them with that. I think just an earlier conversation with our WellSafe partners around technology, I think is another place where we hope to see more improvement. I think anything we start new, we should always be looking at, analyzing, evaluating what's working, what might need to be shifted and modified. It's a regional approach. I think there's some benefits to regional approach, and there's some challenges with regional approach, particularly from a customer's perspective. So I think we have to continue to look at those things.
Yeah, I think I would dovetail on everything that Kelli said. It's very difficult. This is a heavy lift. The concept, again, as I kind of alluded to earlier, sounds simple, But 911, which for the most part, and there are regional 911 centers, but most are assigned specifically to a department, that's had a 50-year head start, and they have systems in place, and it still doesn't work perfect every single time because it involves people, which is inevitable. But I mean, and kudos to WellSpace, who we also contracted with Yolo County for 988 services. The turnaround time and their ability to get the program to a point where it's effective and efficient has been great. And so, you know, Davis Police Department was kind of an early adopter of this concept because we have our own comm center, which is different than the other jurisdictions in the county. So it really gave us the opportunity on a smaller scale to be able to kind of proof of concept this idea of how it's going to work. And of course, there's stumbling blocks along the way. But as everything else, we work through those, we improve those processes. And, you know, it was interesting because I was in the comm center the other day in preparation for this meeting, and I was just asking, how is it going? And the response I got from the dispatchers is good. And that was it. And if you know dispatch, that means it's really good. Because if it's not, they're going to let me know. There's no question about that. So I think it is getting better. Yes, I think the integration of technology and a shared workspace across different entities is going to be huge. And, you know, we're starting to kind of make some headway in that. So for us, we have an after-hours mobile clinician response team that's run through the county, and they contract with AMR for transport services. And so we have just kind of entered into this process to be able to share our computer-aided dispatch information with AMR, and we're trying to fill these gaps, right? And I think those are some of the issues, the technical issues, the mechanics of how this works, that are going to take some time to figure out how to make it more efficient. Because when a system fails, right, or if we have gaps in a system, the vast majority of the time, those gaps are caused by bad communication. And when you have, you know, even in a larger county where you have multiple people involved in the process of a call coming in, that call being triaged, that call being transferred to another person, that call maybe going to 988, that being sent to somebody else, we've all done the telephone game, and we all know kind of how that results. And so as I look forward, really what I'm interested in is how can we have integrated systems where information comes in and it's rapidly shared with the entities that are going to have involvement in it. Because I think that's where we're going to improve some of those communication gaps. And that's really where you want to come up with this shared operational understanding of what's occurring. And we're better today than we were. And honestly, when, you know, the whole concept of 988 came up, I had real concerns around it because, again, our dispatch centers have been around for a long time. Those systems are very integrated. They've been refined over time. We've been able to proof them. And to basically add another component to that, right, there are concerns of dropped calls, missed service, all the dynamics that come with that. But we are overcoming those on a daily basis, and we'll be better tomorrow than we are today. But yes, I do definitely think there's some real opportunity for technology to just make us more effective and efficient and improve communication.
I would agree. I think that analysis is important because you have to look at, for example, we took a lot of pride in the change that we made, but we have to be willing to accept criticism and the perspective from others if it doesn't work. If it doesn't work, then we have to go back to the table and we have to reinvent, which is fine. And the part of all the parties involved, 988, 911, police, fire, everybody needs to come together on a constant basis and evaluate their processes that are in place to make sure that they're effective. We, at San Ramon, because it's a new system, I looked at the last 2 years of statistics. It's not very much time to look at statistics to see where they're going, and there's a wide gap between some of the numbers, but that's to be expected. So we need some time to see, you know, to evaluate the system to make sure it's working, but we also need to collaborate. We at San Ramon review every single mental health call, every single one of them. We listen to the tape, to the dispatchers, the way they presented the call, the transfer to 988 to make sure we're doing it right. You know, we pat ourselves on the back because it seems like we are. But we do need down the line some way to evaluate the calls down the road. How did they go? How did the 988 calls that were shifted end up? How did those patients end up? How did they recover? And we're working right now in our county to try to avoid, HIPAA law violations, to look and receive information on our medical calls with the definitive care, what happened in the hospitals, and then what happened in the long one. Did we really save the patient hospital time? Did we improve their condition by doing it the way we did it, or is there a better way to do it moving forward? So analysis, absolutely. Collaboration, that's very important. Communication between all the parties that are involved is critical. And if we do that, then I don't think, what I was going to start off by saying, but they changed my track, is I'm not the person to talk to, because I look at the cup as half full. And if there's only this much in the cup that's this big, I transfer it into a smaller cup. Because as a firefighter, when we show up on scene, we're not allowed to decide, well, we can't do this. We have to resolve it. We have every single incident that you can imagine, we have to mitigate that problem. We don't have the choice to just walk away and go home. And believe me, there are times where when you're on that call, you wish somebody else was there instead of you, because it's very stressful to have to come up with a solution to a problem in minutes' time to save a life. And, I'm going a little too far on the medical side of it, but I think the same is true for mental health. One of the things that I think about mental health regarding communication is I love working with mental health employees and professionals, because it's a certain type of person, that a quality of a personality that leads you in that direction to want to help people. This fellow that was on the video that we saw when we first started out, he has that gift, that spark. You could tell just by the way he was talking that he had it, but he was missed somehow. So the last arm of the communication process is to really reach out to our communities and get that message out there, that there is hope for them and there are solutions we're working on, and maybe they could suggest to us through communication a better way to mitigate the problem.
One of the things that each of you said, it's become kind of a mantra in the behavioral health space, that everyone should have someone to call, someone to come, and somewhere to go. And I think what's challenging is we have someone to call, still figuring out how we get that to the someone to come direct connection, but we have the someone to come. You're all here. But I think the next frontier is then how do we get people to the place they need to go? Because you all have different rules of engagement depending on mobile crisis teams and what types of transport you're allowed to do. Law enforcement has greater flexibility. EMS, fire, also different constraints. And so a question on one particular program, but feel free to expand out. Deputy Director Weaver, Sacramento has just opted into the state's triage shelter destination program, where paramedics can be part of the crisis response system and take people to behavioral health crisis facilities instead of the ER. How is that rollout going? What is the impact for Sacramentans in crisis? And I'm curious, from the two chiefs in the room, where that program isn't in place, how are you handling getting people to the places they need to go? And what's kind of the future of alternative destinations looking like in your jurisdictions?
Thank you. Yes, it's very new. It just launched earlier in 2025 in April. I'm happy to say that we've had 36 individuals through the TAD process. We have 3 locations in Sacramento that have been identified as an alternative destination: our county-operated crisis stabilization unit, our urgent care clinic, and our WellSpace crisis behavioral health receiving center. And so we have, again, brand new. We're gonna want to sit down with our partners and see how it's going, understand the process from both ends, from the identifying the client to the individual and getting them to the location. Is the process smooth? Are there any glitches? And is there any refinement that we need to do? I would say that what I'm hoping builds out is that we have, right now, my understanding is that our EMS partners aren't being reimbursed for these types of drop-offs. So it limits some of the options. So we potentially could be serving a lot more folks through this process. So I hope to see that expand. But I'll take 36 in a short period of time, and we're excited to continue to learn how this works, and over time see the impact in reducing the folks going to our emergency departments.
Yeah, I think this is probably the most difficult piece of the three prongs, right? Because it's expensive. It requires a facility. It requires personnel to staff the facility. And in Yolo County, this is the space we're really trying to kind of come up with a solution to. I think we're pretty close, but I think this is probably the most critical piece because ultimately not everybody fits into a finely defined box. And we need different destinations to be able to get people not only the right type of services showing up to help facilitate that, but we're getting them to the place that they need to be that's going to fit the care level that they require. And so I think this is definitely space that I hope to see continue to grow because it does help. And for years, when this was mostly strictly a law enforcement response, it was really two options, right? It was, hey, it's a hold at a hospital or it's jail. And thankfully, I think over time, now that we've integrated different components into this, people that actually have skill sets designed for this specific problem, we're getting better in that space. But then the question does arise is if we can't stabilize in the field and we can't build a safety plan, but we're not comfortable at the level that, hey, this really requires a 5150 hold at an ER, what do we do? And I think that's frustrating for the patient. I think that's frustrating for the community. And I think that's frustrating for the responders. Because people get into this job because, regardless of what discipline you're in, because you have a servant's heart. You want to do good things. And I think that can be frustrating for people when they're at this, barrier of what do we do? Where do we go? So I definitely think that, seeing that space grow will be critical, especially for sustainability of this. And there's some great models to look at. There's some great models within our region that are doing great stuff, whether that's Placer County or Sacramento. So we have things that we can build off, but it is expensive. And, as the chief indicated, I have real concerns around ongoing funding and what that's going to look like. And, we're going to find a way, but it makes it really tough. And the field in general has experienced a lot of change over the last few years. I mean, seismic shifts. And just when you think we got over the hump, we get another one. And so I think those are real considerations that we'll have to consider as we start to move forward and develop plans. But at the end of the day, we've got to figure it out.
Yeah, and the way I look at it is this is 2 years in the making with what we're doing. 988's 2 years in the making, 2.5 years in the making. We've just now started realizing another problem has surfaced, which is, okay, now that we have an option, we have somewhere else where our patients can go, where is that going to be? And these meetings, these consortiums and having these discussions with other agencies and with our sisters and partners in the field, that's the next project, right? What's the next project? Well, let's figure out a way to create these facilities for the people that don't necessarily want to go to the local emergency room. The other thing is to collaborate with our counties and the state, but more importantly, our counties for alternative destination approval, because we meet those challenges now. There might be another place that we want to take the patient. It may be accessible to them, but by our standards and our policies, we can't do that. So let's work moving forward.
I'm curious for Deputy Director Weaver and Chief Mohun, because you're more constrained in your ability to take people to different locations other than the emergency room or potentially not transport at all. For you, when you arrive on scene and someone needs a place to go and the best place for them would not be the ER, what happens next? What happens practically on the ground?
So we have, our mobile teams have access to multiple levels of care. So if a person, I think our biggest hurdle is if a person isn't willing to go. isn't willing to get into the car voluntarily. That's a hurdle for sure. That being said, if our team identifies that this person's needs are bigger than just a referral back to their outpatient provider, we have our urgent care clinic that we can bring them to. If they do need a hospitalization, if they need that level of intervention, we can access our crisis stabilization unit. We have other resources also available in our crisis respite program. We additionally do work with we have a really robust outpatient system. And so if we have folks that are already connected with their outpatient provider who are familiar, oftentimes resolving crisis is really around the support system. So it's really creating that safety plan. So bringing, the needing to take somebody to a particular location, hopefully is a last resort, and really, it's really honoring what that person is asking for and what they need. But again, your toolbox for a response team should be really robust with lots of options, with the ability to, our teams follow up with folks if they need to have an in-person follow-up, we can do that. But again, in terms of where we can take them, we do have quite a variety of places to go. If we have a situation where a person's in imminent risk and they're not willing to voluntarily access services, we do reach out to our law enforcement partners for support.
Yeah, what we do is the first thing we do is we transfer to the warm handoff. That's our first. That's at the very first and in the beginning with our dispatch. They transfer 8% of our calls off to warm handoff, and then I would just piggyback on what you said. Then the next phase is if we show up or PD shows up. If PD shows up, they're going to P5150 probably, and they're going to go to the county facility because that's the contract we have. Then after that, the firefighter shows up. If they show up, they'll have a conversation with the patient, and it'll be collaborative. If it's a minor, the parents will be involved in the conversation, and we may not transport at all, and they may have a facility that they decide to go to. That will be their choice. Very small percentage of the calls don't transport because in our little neck of the woods, people want to transport. They call 911. They pretty much anticipate they're going to get a transport to the hospital. We're not getting a lot of negative feedback for that. They're just glad they're not going to the county facility because it's local and it's somebody that they can talk to, a doctor or even their own personal doctor. Again, this is a new phenomenon, and I think it happens a lot in the inner cities where people just don't have access to that kind of care, and that's where we have to focus our energy.
Great. Across all of your systems, workforce is a challenge, and this is particularly demanding work. What changes, training, staffing models, interagency collaboration would most improve outcomes for individuals in crisis and make this work more sustainable over time?
That's a loaded question. Mostly because we're asking a lot of our workforce, and it's different for different types of programs. Speaking on our co-response, we have this fabulous partnership with our law enforcement agencies. We have been able to learn from each other over the last 10 years so much. The clinician rides with their partner and sees things that probably a lot of clinicians don't see, it just in the nature of the work. So there's a lot of secondary trauma that happens. And so it's probably pretty rare for a clinician to be part of that team for a long duration. I think as employers, listening to our teams, listening to what their needs are, what is missing. We're doing that constantly, looking at where are the gaps in our training, what else do we need to do to support, what does wellness days, how do wellness days show up in your workspace and your work environment, so that self-care is part of your regular conversation to support staff. Our co-response program has been hard to sustain staffing levels. I don't know, we've had funding for 11 teams. I don't know if we've ever gotten to 11 teams. It's hard position to recruit for. For our non-law enforcement response, there's nuances to that, but it's listening to our peer specialists talk about what they experience on various calls, and their needs are unique. So it's not a one size fits all. It does require us to really be engaged with our staff, with our team members, and be responsive and be creative to ensure that we're giving them what they need so they can go out and do the good work. These are incredibly passionate people. They are gravitating to this type of work, but we have to make sure that we're giving them the tools and the resources and the support that they need.
Yeah, I think, one of the key components is this, integration, specifically maybe to law enforcement and these clinicians. And so this is an issue that's near and dear to me for a lot of reasons. But, we've really brought our clinicians into the police department, and it's seamless in so many different dynamics. And I think that is such a critical piece to this. Because if they're seen as a separate entity that just works with, we're not going to get to the space that we need to be, because we need to be one team, and that needs to be a command climate, and that needs to be reinforced, because I think that really improves the dynamic, because they can learn from each other, and they do learn from each other. And those impromptu conversations at the end of a call where a clinician who has training and experience in this space can talk to a police officer who most likely did not get into this job to come to mental health calls, is invaluable. And they talk about it all the time. And I love it because, I'll walk into a briefing, where the patrol officers are coming in to prep, and our clinicians in there, and they're having shared conversation. I'm like, okay, we're getting there. This is good. So I think that's a critical component. Kelly's right. It is tough to recruit for these clinician positions. And it was interesting because when I was sitting on the interview panels in 2015-16, I was surprised, right? There was a small number of people that were kind of interested in it. And I'm married to a clinician, so, obviously we have conversations around this, and she's like, I don't think that would be for me. But what I really love to see is a better opportunity to incentivize people coming into this specific field. And I think some of the mystery around what a mobile clinician in the field looks like is probably starting to dissolve. But when people get into it, I would say for the most part, they love it, because it is very rewarding. And there's aspects to it that are very different than any other kind of clinical work. And so from my perspective, I'm like, because I'm doing the same thing with police officers. How do I get good people to want to do this job? And I really look at it the same way, because, we have 2 clinicians now, but we went for 2 years where we didn't. And it wasn't a matter of we didn't want to. It wasn't a matter of we couldn't fund it. It really came down to, how do we get people to do this job? So I think when we talk about workforce, for me, that needs to be a priority. And I would really love to find ways to incentivize people to get into this specific type of work, because I think when they get into it, they're going to find it extremely rewarding and beneficial. And so I think that space that would be great to kind of explore, because the concept is good. If we don't have people that can come and do the work, it's all for naught. So I definitely would love to see improvement there.
Yeah, and I would agree, peer support is important. You need to be able to monitor your clinicians to make sure that they're not affected by their calls in a way where they themselves now become the patient. And what we've done at San Ramon, and first I'd like to say that, each and every one of us, and I never really referred to our firefighters or our medics as clinicians, but I guess we are, because we didn't have a choice. We're going to 5150 calls, and even if we wanted to get in to fight fires, we're going to 5150 calls. And in that line, we have mandatory training for our employees. All of our employees go through a mandatory training session with professional psychologists that we've hired for the district, and then our new employees go through the training fresh. We're now working on a wellness plan for our employees, because we've recognized, and this is what happens. You start to go into the rabbit hole, and you start realizing, oh my God, firefighting and police officers, they have a tremendously high suicide rate. and a lot of PTSD. So now we're realizing, well, why are we not looking at our internal customers and giving them the same opportunity for growth? And we're in the process at this time of implementing a wellness plan for our employees. So just to underscore what they've said and what these two have said, the training is critical, but you have to attract people to the field. Our firefighters have been doing this for years. They have thousands of hours of clinician work because that's what they've done over the course of a 30-year career. It isn't as bad as you might think it is. It's actually challenging and rewarding. The best patients I ever had were patients I transported to county. And the reason was because, number one, we had an hour and a half transport, so we're going to talk about something. And number two, I'm a little crazy myself, so I think we had a lot in common.
Well, to wrap us up, this is the Vision 2030 Solutions Symposium, and you have a lot of folks in the room who are the decision makers at the state level and the folks who work on the policy here. And an unfair question, but if there would be one thing that you would prioritize as a change to help elevate crisis work and make it better for the people on the ground, what would that be?
I'm going to fail at one thing. I'm just going to start there. I think that there's key. I think we need to look at the policies that are supporting or potentially hindering progress. We want to make sure that we're continuously invested in our relationships. One thing that was said earlier that cannot be understated, which is having champions. Within all of our system partners, having a champion lead the way in this work is critical. And as long as we're coming to the table with a problem solving mindset, and I just want to, as from a behavioral health lens, we talk a lot about mental health, and we oftentimes interchange mental health and behavioral health. I please cannot underscore enough that when we're talking about behavioral health, we're also talking about when folks are showing up with addiction and substance use needs, as well as mental health, and that when we're looking at solutions and how to meet the person where they're at, we have to take all of that into consideration. So training is really important, messaging and marketing these resources so that community knows that there's an alternative to 911 and there's alternatives to hospitals.
What she said. No, I absolutely agree with everything that she said. I mean, I'll be honest, the one thing that I would love to see is more funding in this space. And I know there's a lot of pieces to that, and it's a very dynamic conversation as to how that actually occurs. But I think it is important. And what I don't want to see is us slipping back and losing any of the progress that we've already made, because we're in good space. But never best, only better. We have space to go, and I want to continue that momentum. I think outside of that, what I would love to see is we're still in this development stage of what this looks like. We're still trying to build our own best practices, and that's great. But some point, getting to a place where there's consistency and standardization across the board for all 58 counties, I think will be great. And not only HHSA or behavioral health departments and ERs, but also fire and law enforcement, right? We're definitely, I think, closer than we've ever been. But I can guarantee if I go down and talk to 332 different police chiefs or 58 sheriffs, they're going to have a different approach to it, and they're going to prioritize it different ways, and they're going to invest in training to different degrees. And to get better, we need to be able to set a bar, and a bar that we can all reach. And there's definitely, we're better than we were, but we have room for growth. And really what I would like to see is more commonality across counties, because that's ultimately, I think, the goal is we go, hey, these are the programs that are working. These are the jurisdictions. These are the counties that are just doing it well. Great. Let's model off that. Let's make it better, and let's share that so that others can get there. And there are obviously, counties vary, and we're going to get there at different speeds, and we're going to get there to a different degree. But I think going forward, that's something, outside of a windfall of money coming to the programs, but that is something I would absolutely love to see.
Okay, so I believe in reaching for the stars. So what I'd like to see is a cure for all the mental health illnesses that are out there. And I don't say that. The reason I say that is because that's what we need to do in this particular area. We need to reach for the stars, because we just can't accept it that we're going to inch forward at a very slow pace to resolve what is a very serious and significant issue in our society. When you look at the number of calls, we have the second highest number of calls in our district is mental health, second to trauma. And that's second to all the trauma. That's second to the person that cuts their foot or they get a shaving cut, all the way up to the accident where they're ejected out of a vehicle. But the point is, I would say that if you subtract all the minor traumas, mental health is probably the most significant, the number of calls that we have are mental health calls. And why aren't we doing anything about it? Why isn't it as, why doesn't it come across as something that's as, when kids want to be medics or firefighters or police officers, that's really cool. Do you realize that you're getting into a business where the majority of your calls are going to be mental health? They don't realize it at the time. But I said it earlier, once you start responding to those calls, they're the calls that you get the most satisfaction out of, because the person isn't bleeding, they're not vomiting, they're not unconscious or unresponsive. There's somebody that you can actually talk to and engage with if you have the ability to do that. My reach for the stars would be to popularize mental health. That's what I would want. I would want it to be something that's not parked off into the corner somewhere and nobody gets to see it. It would be something that if you have a mental health crisis in your family, everybody shows up to the hospital with balloons and cakes and cards, and they celebrate your recovery the way they would celebrate the recovery of a traumatic injury. That's what I would like to see, and I think that begins in this room. I think it begins with our influence over the community to let them know mental health is not something that you should be afraid of or something that you should deny. It isn't something that when you hear that somebody has mental health, your first instinct is to say, well, that's not me. It isn't something that when you yourself are experiencing a mental health crisis, you don't say to yourself, well, this couldn't be me. I'm not one of those people. This has to be something else. And you try to write it off as a physiological condition. So with the people that I know and love in my family, and the friends that I know that have experienced mental health and that have held it bottled up inside of themselves for so many years, all of their pain and suffering could have been avoided if they realized, you know what, mental health is actually kind of cool. That's what I'd like to see.
I think that is a great note to end on. Thank you all so much for your leadership and work on the ground and sharing your insights today. Thank you.